All right, great. Good afternoon, everyone. It's really nice to have you join us today for our latest in our series of COVID-19, an update for the business community. Today, we are very grateful and privileged to have Dr. Mendoza back with us. This is his second series that he is doing for us. And Dr. Mendoza was born and raised in Mexico City. And after graduating from Anahuac University in Mexico City, he went to the University of Miami Jackson Memorial Hospital to pursue his degree in internal medicine, pulmonary, and critical care. He has been in Northeast Wisconsin since February of 2001 and has held many positions during his career at Aurora Baycare Medical Center, including Chief of Pulmonary and Intensive Care Unit Departments and elected Chief of Staff. In 2016, while doing all of that, he also obtained an additional certification, interventional pulmonology. So please welcome Dr. Mendoza. Thank you so much for joining us today.
Thank you so much, everyone, for attending this webinar. And really, I feel honored that you guys give me the opportunity to speak and to spread the word a little bit more about this condition. And let me just see how I'm going to move my. Okay, yeah, all right. So today we're gonna do an update because in the previous webinar I talked about what is the virus and how the virus affects the body and the different medications that were approved until then. And this is a month and a half later, and now I just want to concentrate a little bit more on what we have. And first, in the state of Wisconsin, about 10% of the population has been infected with the virus so far, which is we're far from achieving what is called herd immunity. Uh, uh, and then um, new cases about 3,000 per day. And so, and then, as you can see, there was a case of 7.8 cases over 7.8 change over the past 7 days. So what these numbers are telling you is that it's been, even though there are many Wisconsinites affected, there's still a minority. We still have a lot of people that potentially can get infected. And the numbers, as we were anticipating for December, are not looking good. If we consider that about 10% of each of the patients eventually seek medical attention, they go to the emergency room, to the urgent care, to the hospital, and about 8 to 10% of them they are in the hospital. Out of these 3,000 new cases, for instance, from yesterday, many of them will end up in the hospital, utilizing services and further contributing to the problem that we have already. The hospitals are busy. So there have been about 18,000 people ever hospitalized. But right now, as we speak, 1,600 are in the hospital, of which about 370 are in the intensive care unit statewide. In northeastern Wisconsin, the numbers fluctuate, but probably half of what we are seeing, somewhere between 140 to 150 patients are in the hospital right now in the hospitals in northeastern Wisconsin. A substantial problem is the long-term facilities, the nursing homes, and as you can see, out of the close to 4,000 deaths, about 1/5 of them have been related to epidemics in the nursing homes, and they continue to be a vulnerable population, and that has been one of the rationales for the distribution of the vaccine, as we will see later on today. And And not everything is bad. And the good news is of all these 400,000 people in the state that have been infected, most of them, of course, they have recovered by now. And about 4,000 people are dead, unfortunately. And the minorities in our state have been affected. The majority, the frontline workers, the people who work at the dairy farms, people who live in close quarters, people who work in the food industry, just washing dishes and preparing food. Those are frontline workers as well, and they don't have the luxury of working from home like I am doing right now, or many of you are doing right now. I'm not at home, I'm in my office. But those patients, those people are exposed, and naturally they are the bulk of the people who are infected. So Hispanic and Latinos, they've been infected, and many of the deaths are in that group. And then Native Americans also. A lot of deaths in the Native Americans, and the third group is the African American population. So minorities in our state have been affected, are taking the blunt, and the main is not racial disparity, is poverty. Is the fact that a bus driver has to go on and drive the bus, and the same for a McDonald's frontline customer. The one that takes the orders, they have to be there, and they don't have other choices, and so on. These are the statistics that I have from the Children's Hospital in Philadelphia, where, as you can see, the numbers in Manitowoc County, until the end of December, they were to the roof. They were off the charts, and that's why you can see the graph that exceeded what was the scale. The only good news is after that, it looks like the 7-day average positivity rate has slowed down. This is after we have seen that trend in northeastern Wisconsin. It looks like there was a pause right now immediately after the holidays, where people stay put, and they scaled down the holiday celebration, and it looks like we went from about having an average of 40 patients in the hospital. Right now we are about half of that, waiting to see what is happening, and we know that with those numbers of 3,000 people positive yesterday, we know that eventually they will find the way to the hospital. So this is just a little break during this week, waiting for the next trend. And Manitowoc County, it is not the exception. I showed this slide during the last talk, and I just want to show what is the virus. And what I want to point out is that the 2 vaccines that are in the process of being approved are vaccines that are aiming to produce one of the units of the virus. They do not produce the virus. The way they work, as we will see, they are by producing in a semi-natural way antibodies against the spike protein. So the spike protein is the very outer layer of the coronavirus. Corona means crown in Latin, and the spike protein, it just makes a crown around the virus, and that's why it's called coronavirus. And so the RNA information that is inserted in the vaccine and then eventually finds its way to our own immune system cells will produce only the spike protein, but it will not produce the rest of the virus. So the body will produce antibodies against this spike protein. And there are other vaccines that are also in the process to be approved, but they're a little bit behind. They will use a viral vector, and they will inject more information of the virus, and I will explain to you. But that's why I put this slide, just to show you again what are the main components of the virus. And then this is a reminder about how infectious the COVID-19 is. So this is what is called the R number. An R number is a number that the epidemiologists and public health experts use to quantify how easy the transmission of certain diseases behave in an epidemic. We can affect this number for better or for worse through different factors. For COVID-19, the R0, R0 number, it is about 2 to 2.5. So one person with the virus, in average, except for the super spreaders, in average infects 2 or 2.5 other people. So when the disease is out of control, it goes in a logarithmic fashion. And the problem also is that it has a long incubation period. We'll see in the next slide. But it is, for instance, slightly less contagious than Ebola, and is slightly less contagious than the others similar viral illness which happened in the early 2000s, the SARS and the MERS. Both of them were epidemics that never reached beyond Asia or the Middle East because they have less reproducibility. They didn't infect as many people as fast as the COVID-19. The MERS, for reasons, many reasons, it was self-limited, but potentially the MERS could have been the next big pandemic. But again, as you can see, SARS, MERS, and the COVID-19, the three of them are coronaviruses. And what they have in common is they are the result of a mutation. The life cycle of this virus includes permanent mutations, and sometimes a virus that normally will infect certain mammals eventually mutates and now is capable of infecting humans as well. And what I want to say here is we have this big pandemic, but we will have another pandemic with another coronavirus. We don't know when, but it will happen again. So hopefully what we are learning from this pandemic as a society, as government, public health experts, and we have to learn about the next pandemic that will happen at some point. And why we're seeing more coronavirus-related pandemics is probably because as we grow population-wise, we are invading more natural habitats of different mammals, bats, and other mammals, and then the disease will be will jump from infecting just an animal to humans as well. So now, because of that, we're seeing more and more frequently these pandemics. And then again, I want everyone who's listening, watching this, just to remember this moment. And then once we get out, we are not free from the next pandemic. We need to start looking for measures to prevent, and then we need to be prepared for the next one. So again, the reason for the quarantine and the isolation is that a lot of people have very little or no symptoms, and it takes 7 to 10 days for people to start showing symptoms. So in that process, a patient could be spreading the virus without knowing that they have the infection or before they show symptoms. So only very few people show symptoms within 2 days. Very frequent question that I ask to all my patients here. So where do you get it? And many, they cannot answer. They just don't have recollection about what happened 2 weeks ago. Only until they start just like, okay. So it's very important because people cannot put A and B together. Well, I haven't done anything. Well, the effect of what happened during Thanksgiving, it's just going to start seeing now, 2 weeks after, because of the way the virus behaves. And that's why it's been very difficult to contain. This is nothing, the influenza symptoms, they happen faster. In 2 or 3 days, after being exposed, if you have it, 5 days maximum. So it's easier to quarantine people, easier to track people during an influenza pandemic as compared to this COVID-19 pandemic. So that's the challenge, the contact tracing. At the end, I will put a slide that summarizes what we need to do to contain successfully this pandemic. I jump right away because since the last talk, there was only recently the dexamethasone was going to be approved. In this slide, what I want to show you is that this was a randomized study that show they did in 6,000 participants. And as you can see in the different graphs, the patients that received the usual care but not dexamethasone, this is cumulative days after they were included in the study. A lot of people were dying in the intensive care unit while on the ventilator, but the people who were receiving dexamethasone, they were dying less after receiving this medication. There was a difference between the people who received placebo and people who received dexamethasone. This is patients on the ventilator. Patients who were on oxygen, they were dying. These were people who were not on the ventilator. Half of them were receiving dexamethasone, and half of them, they were receiving placebo, and the same. There's a difference between the two groups. And another difference in people who were not on oxygen. Dexamethasone in this study was helpful only if on patients that were in the hospital within 24 hours of admission to the hospital. So that's the main reason why right now dexamethasone is only indicated for people who have COVID, who are admitted to the hospital, and within the first few days of admission, and is given for a total of 7 days. But other than that, we do not have any evidence to prescribe this medication before a patient gets to the hospital or after 7 days of being in the hospital. So that's very important. And this is from the New England Journal. So I'm just trying to show you what is the evidence and why we're prescribing certain things to some people, but why we're not prescribing to others. And now also, President Trump, he received monoclonal antibodies and other, Rudy Giuliani, probably he did receive monoclonal antibodies on Sunday night when he was admitted. And we don't have as strong evidence for these monoclonal antibodies. I will talk a little bit more about it. But in this study, again, in the New England Journal, what they show is the viral load. So they measure how much virus they were shedding, these patients, as soon as they were diagnosed. And in day number 11, there was a substantial or progressive decline in the number of viruses detected in the bloodstream. And they try placebo, and they tried different dosages of the same medication, which is an intravenous medication. And only one of the dosages of the monoclonal antibody worked better than placebo all along. And that is the rationale for this medication. And this is the rationale for this dosage of this medication, which now is available. So this medication, as you can see on the slide, unlike dexamethasone, has not shown any impact on mortality. We don't know yet if the use of this monoclonal antibody will prevent from you to die. It looks like it prevents for many people to go to the hospital. We have data about that. And maybe if you end up in the hospital, it will shorten your hospital stay. But we only have limited data of 452 patients. So we need longer and larger studies to see if this medication may affect mortality or not. How this medication is given is a 1 hour infusion. And the minute a patient is diagnosed with COVID and the patient has COVID symptoms and the patient is not in the hospital, that is the main indication for this monoclonal antibody. So somebody who starts having symptoms, gets diagnosed, it's eligible potentially to receive the infusion. Now, the problem is that the infusion, it lasts 1 hour and it requires staff. So right now in the hospital, there is an area where some infusions can be given. And then we're trying to get 2 or 3 people at a time. But again, the logistics of hundreds of people waiting for this, is what is concerning for many healthcare institutions. And also the fact that they don't have enough monoclonal antibodies. So it's another tool that potentially can be helpful. And the reason why you haven't heard a lot about it is because we're having trouble with that. We have it, and we are doing some triaging to see which patients can receive the medication. But again, it's only for people recently diagnosed with symptoms before they get to the hospital. And the idea is by using that will prevent for people to make it to the hospital. We will know soon if that is the case. But that's another medication since the last visit available in the toolbox. We have also Remdesivir, which has, the only thing that we know is that shortens the hospital stay from 11 to 8 days. But again, just like monoclonal antibodies, we do not have substantial data on mortality. And the data is so minimal about that the WHO did not recommend for this medication to be included as part of the protocol in many other countries, not only because it's a very expensive medication for other countries, but also because it doesn't show a substantial benefit. We're using it, but again, it's not a make or break medication in my opinion. And along with that, we have convalescent plasma donated from people who already recovered. It's just similar to the monoclonal antibodies, but just with other type of antibodies. And it is useful probably on people who are recently diagnosed and are admitted to the hospital, but in a certain group. But it's not, again, a make or break medication. And recent data showing that is not as promising as once upon a time we thought it was. So we have very few medications available that are truly useful, and we don't have anything left but supportive care, oxygen and IV fluids, and exclude other conditions, prevent blood clots, etc. And so we have, again, as I told you, we have the RNA vaccine. And this is what we have available now, the 2 vaccines. And then we have the next one online is probably the viral vector, the AstraZeneca in conjunction with Oxford University. They have a virus. This is called the ChAdOx. ChAdOx stands for chimpanzee adenovirus, and Oxford, ChAdOx, ChAdOx. And it's a virus that affects only primates, but for for a long time, we know that does not infect humans. And it doesn't cause any disease because it doesn't affect whatever it produces is of no consequence to us. But they use that virus as a Trojan horse, and inside that virus, there is genetic information produced artificially that once encounters the human cell, allows for the process of genetic information to be transferred to the factory of our cells, our own immune system, and they start producing antibodies against that. So our body thinks that this is a real virus, and then once the virus infects the cell, it infects with information, part information of the COVID-19 virus, and then it stimulates the immune system to react against that. That it is not available yet. That is the British vaccine AstraZeneca. They have a large trial. They paused 2 or 3 times for safety reasons to double check that there were not major side effects or complications related to the vaccine, and they continue. And the problem that they are having is that they use a subcontractor in Brazil that apparently was not able to fill out some forms correctly. So the data is a little bit skewed. They're correcting that information, and that's why they are behind the curve. And by January, we will know more about this vaccine. But it's a good vaccine. And the same, the CanSino, which is one of the Chinese vaccine, it is working with a vector, with a viral vector. This viral vector has been successfully used in the Ebola vaccine, and a lot of people have been vaccinated with this type of virus, in this case for Ebola, and with no long-term consequences. So we have some data from previous vaccines on this one, but we don't have that data, and right now it's not even in the process of application of approval for the FDA. We are at least 1 month away. What we are is the RNA vaccines, for which we have 2 of them. And the first one that shows some data is the Pfizer vaccine, and which is a joint venture between Pfizer and another small company out of Germany. And what they do with this is they artificially have the information, the code of information that is called a messenger RNA, which is one of the smallest particles of the genetic information of a virus. Grossly speaking, we have DNA viruses, which have DNA, just like us. And then there are RNA viruses, and coronavirus is one of those. They have RNA, which is the messenger that goes between the nuclei of the cell to the factory of the cell, which is the ribosome. So that messenger goes from that with the information to, okay, this is my order. This is what I need for you to produce. So very cleverly, this RNA is has information to produce the spike protein for the coronavirus. That little outer cell is the only thing that is producing. This technology has been available, has been on the work since the 1990s. It's the work of people from Harvard. And it has been tried multiple times on people with cancer. And that's how they were working on that. They were perfecting the technique because the problem is our body it degrades quite easily the RNA. So the RNA, once injected, it didn't last long. It couldn't reach the cells without being broken down. And then, so now they were able to find a fat envelope that will travel in the bloodstream, will find cells, and those cells will start producing just exclusively um, through using our own ribosomes, we'll start producing this protein, which is called the spike protein. So in a matter of 3, 4, or 5 hours, once it reaches the cell, a cell start producing lots and lots and lots and lots of this spike protein. And again, inside the cell, there are enzymes that will break down the RNA in few hours, and then the RNA disappears forever. So that's a beauty. I mean, you produce and then it goes away. And then, but that spike protein is in the bloodstream, and the immune system say, "What's this?" And then the immune system then starts producing antibodies against the spike protein. The spike protein is the one that binds to the lining in the respiratory tract, and from then finds its way to inside the body. So by producing antibodies against this, you prevent the infection. And I will show you a little bit how herd immunity works, because now that we're talking about vaccination, I'll show you how in red you see when no people is vaccinated, how really fast the infection spreads. And when you have 25% vaccination, it's slower. When you have 50% vaccine, it's even slower. And when you reach the 75%, is when you say that you have herd immunity, because then it will be a lot more difficult for the infection to spread. And 90%, well, even better, 95% even better, because you barely get to see any infection. So achieving herd immunity through the natural way is a very risky proposition. I already told you, out of the 4 or 5 million people in Wisconsin, only 400 have been infected, and not all of them have antibodies. You know that about 1% of the people will die. So in order to achieve herd immunity, you will have to infect another millions of people, and then in the process, many of them will die. And not only that, the people who don't die, some of them, they end up with long-term complications. I have a patient right now that is 35 years old and still cannot, I mean, it's been infected for more than 2 months and still cannot get better. So it's and then many people 60 days after diagnosis of the virus with infection, they still have symptoms. So it is a very risky proposition, and vaccination is your best path to reaching this so-called or the famous herd immunity, for which I'm showing you an example. And so I'm going to talk again about the RNA vaccines. I explained to you a little bit how it works, but I want to show you how fascinating the journey in less than 1 year has been, because in December of a year ago is when they start having the pandemic in China. In January 10, the sequence, the genetic information of the virus was very transparent, given to the world, so we can work on it right away. And in January 15, Dr. Fauci sat down with the chief, because they were working on RNA vaccines already. So sat down with one of the chief strategists for RNA vaccines and say, can you produce that? This is, you have the genetic information, just put together everything, and then so you can start working on a vaccine. And by March, Moderna was already working on experiments. And then by May, Pfizer was already working on experiments. By July 14, There were the first subjects that were injected, and some of the preliminary data were already published. And um, by September, October, there was enrollment already in happening. 30,000 people in one for one vaccine, and about 20,000 people for the other vaccine. Half of them receiving placebo, half of them receiving the vaccine, checking for every side effect that you can think of, measuring antibodies, measuring what is called neutralizing antibodies, because T cell immunity is equally important as B cell immunity. You need both to successfully prevent for the virus to happen again. And then finally, November, we have the data of efficacy. And right now, on Thursday, as we speak, the FDA will sit down with the advisory committee, people, very talented people from around the country that has looked at the data provided. Is not available to us yet, but on Thursday is going to be available to the public. Everything is 10 hours of grilling meetings until they decide if it's safe to release these vaccines to the public. And of course, that happened in the United Kingdom already. And so there's a reasonable chance that at least the Pfizer vaccine may be FDA approved in an emergency basis. And the same thing will happen with the Moderna vaccine a week later. So the 10 is one meeting, and the 17, 7 days, because the same scientists and public health experts and vaccine experts will have to sit down and read and go over all the paperwork produced by the Moderna vaccine. So a lot of work behind the scenes. And at the same time, the Pfizer vaccine in Kalamazoo, Michigan, is being producing millions and millions of vials of the vaccine and storing in a sub-zero. And this is kind of like a risk for them, because Pfizer never took any money from the government, from taxpayers. They funded their own vaccine, and they're doing this at their own risk. And if they get FDA approved, they're ahead of the curve, and they will be able to quickly distribute all these vials of vaccines. And similar to the Moderna. So they're already, right now, vaccine ready to be distributed, and then in the next few weeks. A week ago, there was a meeting just to decide which groups of individuals were going to be receiving the vaccine. And so right now, we know that we need about 40 million vials of this vaccine because it's 2 shots. So we have 13 million healthcare workers, which they decided were the first, and nursing home residents. So about 20 million people need to be vaccinated in 2 separate shots. So that's how they're going to start. And as you can see, how we're going to try to get to 330 million Americans. So it's going to be a massive undertake that will take several months, if not the entire year, before we can get there. So as you can see in the graph, we need at least 220 million vaccinated people for us to say, okay, time to slow down and not to wear masks and go to all these things that we remember from the not so distant past. We will not be out of danger until we get that. Until then, we need to follow the same guidelines, even if you receive the vaccine, because at this time, we know that it prevents symptoms of the infection. It prevents hospital admissions. But we don't know yet if you still can acquire the virus and then give it to someone else without you having without infecting others. It's possible that not. We don't know that yet. And so until we know better, in the first few months, we still have to behave as much as we can in following the same guidelines. So I show you the graph about how herd immunity works, and then I show you why we still have several months before we can say, okay, this is not like a switch on and off. This is going to be a dial down. We're going to start seeing less and less people infected, but it's going to take several months before we can see that effect. It's not going to be immediate gratification as we have been waiting all along. And so until then, speaking to this Manitowoc Chamber of Commerce, we really appreciate what you do, because you maintain our economy healthy, you feed us, you maintain our supply chain, and you are extremely important for us healthcare workers. As members of society, we recognize what business does for us. And so we are in partnership with you, and that's why I'm doing this as a partner to you, to my community. But until then, we need to work together to save lives, to recover the economy, and to restore the community life. And this is not just one medication or one vaccine or one wearing mask. It's the combination of everything. Which starts by wearing masks, which have some effect in reducing the R0 number, the infectivity number. The same for maintaining social distances, avoid gatherings. As long as we have 3,000 new cases a day, it's next to impossible to do proper contact tracing and to isolate those people. In countries that they have been successfully and very aggressive in doing that, like Korea or Taiwan or New Zealand, it is easy to identify an index case and then all of a sudden send the Army, the Navy, the Marines, isolate them, get the contact tracings, isolate the other people, and stop the disease from spreading. But when you have 3,000 new cases a day, it's next to impossible. It's impossible. We need to make the epidemic more manageable, and we need everyone's. And then, of course, as I show you, nursing homes have been an issue. 1/5 of the deaths in our state, unfortunately, happened for somebody's grandmother or grandfather that unfortunately acquired the virus and died, isolated, without having the loved ones without dignity. So we need to protect. They are vulnerable, and that's why we're gonna start vaccinating a high-risk group. And washing hands. You know that mobility is associated to the spreading of the virus. So right now during the holidays, the more we can avoid traveling, the better. And of course, I've been extremely careful trying to acquire the virus. It's been 9 months. I've been successful. I've been using my mask, my goggles, my face mask. But I'm always in the fear. I'm otherwise healthy, and I think I have good chances to do well if I acquire the infection. But if I acquire the infection, I have to be out of commission for a couple of weeks. And my patients and this hospital and this clinic and all the things that I do, I mean, I cannot afford to be sick and not be available for my patients. And the same happens for a nurse or a respiratory therapist or a lab technician. If they go down, we suffer. So we need to protect healthcare workers as well. So it's the combination of everything and working together, joining forces. We are by the finish line. This is when we need to stay on course and do the second effort. We start seeing the light at the end of the tunnel, but we need to stay united as society and educate and stay together. And again, this is almost the last slide. Just yes, I don't want to picture paint everything negative. The vast majority of people do well, and this is great news. But I do not, even if I'm healthy, I do not want to buy a lottery ticket where the raffle, where I'm gonna have 5 in 100 chances of getting the big prize. I just don't want to get into that lottery. Nobody wants. So that's what I have for you. I'm gonna put mute right now. I will entertain any question. I have a question. How does a person find out if and when they are eligible to get the vaccine? There will be massive public communication. Um, uh, right now, healthcare workers, they will receive notice right away. They're going to be eligible. And then after that, phase 1A and 1B are ready, there's going to be massive communication from the CDC, from the state. It's going to be super announced, and there will be logistics about where and how and who's eligible to receive the vaccine. And believe me, I mean, we're going to make sure that people who are eligible know, and then we're going to try to encourage them to come for the vaccine. And I want to mention people who are kind of leery, and it's natural to be afraid about new type of vaccines and everything. I've been tracking this, and I've been seeing, and I don't see any side effect, major side effect. I've seen side effects of getting the infection, people dying. That I have seen. I don't see of the trials of the vaccines. I don't see people dying. We don't have long-term data, but we don't have but 9 months of data of COVID-19 infection, and we have 300,000 people dead or close to. And so one vaccine, it's and by the time it gets to more of the general public, you will have by then 8 or 9 months of data and millions of people vaccinated. So again, you will receive communication. And right now, because we're in transition of a presidential team to the other presidential team and the CDC, we will know more soon. What it is an abnormal positive? Well, I don't know what you're talking about, but we have PCR test, which is what it tells you if at that specific time you have the virus in your system at that specific time. That is very reliable, and usually that does not give you an abnormal positive. That gives you positive or negative. You have then the antigen, which is the rapid testing, and that can have some false positives and some false negatives, and sometimes they see some signal, but it's equivocal, and that could be one of the abnormal positive. And then the other thing that I have seen abnormal positive is the virus, the antibodies, which is to see infection from the past. What if in the past 2 weeks you were exposed to the virus and able to mount an immune response and you have antibodies against the virus? That sometimes can show false positives or have a signal where, hey, yeah, I see some antibodies, but you did not reach the threshold for us to call this a positive testing. But I will need to know more about exactly what whoever asked the question, what are they referring to, so I can elaborate more. Another question: if I get a choice, how can we determine which vaccine to receive? Both? I don't think we will have a choice. The choice is you go for the vaccine or you don't go for the vaccine. Unfortunately, right now, we are dealing with a supply. We don't have enough vaccines. They are being produced. So right now, the two available are Moderna and Pfizer, and all together probably will get us to the 40 million. And then the next batch will be probably another 100 million vaccines that we need right away. So who has that vaccine and available? That probably will determine which vaccine you will get. Now, I don't have enough information to tell you if the RNA vaccine is superior to the DNA vaccine, and which one of the two will give you longer lasting immunity or less side effects. There's a lot of enthusiasm in the RNA world because of what they are seeing is just fantastic, because they were anticipating this. They did many trials during the MERS, and so they were ready for this. And what they're seeing is probably this will be one shot. It's possible if you have enough T cell memory effect, that T cell immunity will carry you for the rest of your life, which that means that a lot of people that receive the RNA vaccine essentially will cancel the pandemic. But the virus will be there. So we don't know. We don't have that information. And probably that question of which choice of vaccine we will be able to answer by April or May. And if you're one of those that you were not priority and now you have three vaccines, at that time you ask me the question and I will be able to elaborate more. How long are you estimated to be protected after the second shot? 3 months, one. Well, right now, we know that the antibodies and the good antibodies actually better in some instances than the natural infection, a lot better, by the way. They have been sustained, and this is what I'm saying. They have been sustained for at least 4 months, and then from the very first patients that received the very first shot for 6 months. So we have 4 months solid data, and the level of antibody is not showing any downward trend. It's being sustained. So we will know in 1 month if it's 5 months or 6 months, but that is gonna be good enough to get us out of this mess. And then we will know it will be a once a year vaccine or once in a lifetime vaccine. We will know. Then, is there a difference between the two vaccines that are coming out? Will one be more effective than the other? We will know more, but at least by the press releases and the initial data, both the Pfizer and the Moderna are very similar in efficacy. And again, in the other, the adenovirus, the one for AstraZeneca, which is the third in the pipeline that probably will come, they have some issue about 60% efficacy, but that is probably related to that problem of the SKU data by this contractor, and I'm trying to sort that out. And that's why it delayed this application process by a little bit, but we will know a little bit more. So right now, both are equally effective. Both are 2 shots, 3-4 weeks apart. Both of them, they have to be stored in freezing temperatures. But then I don't know which one of the two. One is good off the freezer in the fridge for 2 days, and the other is good off the freezer for about 5 days. There's subtle differences, but overall they are very, very similar because it's the same technology. Different companies though. Then should a healthcare worker who has already tested positive for COVID and recovered get the vaccine? Excellent question, Richard Markham. The trials for the vaccines were done on real people who had already symptoms and showed they had antibodies for the infection, and people who have never been exposed, because they want to simulate real life and real people and real community conditions. So the vaccine was received by both kind of people, and We will know a lot more, but it's possible that the vaccine will be recommended for everyone, whether you were exposed or not. And one of the reasons, again, is because often, if you have mild infection or you have no symptoms or very little symptoms, it is possible that you get your antibody testing and you have zero antibodies. I've seen many people already. That doesn't mean that you don't have some degree of immunity, but probably your immunity is weak. And that's why we are seeing more and more cases of reinfection. You acquire the infection, recover, and then 2-3 months later, they reacquire infection by another viruses, by another COVID-19 virus strain. And so that's why it's recommended. Probably people who had the infection will not be first priority, but yes, yeah, it's possible they will be recommended for that people. How is the staffing of the hospitals where you practice in Green Bay and in Manitowoc County at the present time? Are they able to handle the volume of COVID patients and others? Thank you for thinking of us. We are tired and we are under stress. As I'm giving here the talk, I have a bunch of phone calls and things happening. So yes, we're under stress. A lot of people, they are, using overtime and they don't have as much rest. We're prepared. We're united. We're together. Fortunately, in Aurora Bay Care and the Manitowoc Aurora Hospital, we're part of a large organization of 70,000 employees, and we have some flexibility in resources and then cross-train and send people to help. But still, I mean, we have staffing issues and like anyone else during the pandemic. But thankfully, we've been able to handle this. At times, particularly about 10 days ago, it got really scary, where I didn't see an end. This week is a little bit better, and I'm just hoping for the second wave not to be as hard. But at times we have to be very creative with room usage and who gets sent home, and discharging patients. It's difficult too, because sometimes we don't have all the resources. Okay, this patient only needs a little bit of oxygen at home for a few days. Well, maybe there's no oxygen concentrators available because there is a scarcity of it. Or home health. Maybe there are not enough nurses in the home health system that will be able to provide the services needed, or sending a patient for a rehab facility. So we have all those issues because we're part of the community, healthcare community, and then we've been doing modifications about things that we can do and we cannot do or should not be doing at the moment of this pandemic, trying to accommodate for everyone. But thankfully, we've been able to manage. We're just tired and we are under stress, hoping that this doesn't get worse. How is the staffing of the hospitals where you're practicing? No, that I already answered that question. We know healthcare workers will be receiving the vaccine first, but we work in many fields. What about home care workers, RNs not in the hospital but at risk? Are we included first? Any healthcare worker should be included. I don't have any say about the distribution of the vaccine and how they're going to be accounted for, but anyone who works and cares for patients is considered a healthcare worker, and that will be the first priority. It's not only nurses and doctors. No, it's workers at the nursing homes, people who work in the preparing meals at hospitals, at nursing homes, environmental services at healthcare facilities. Those people, they are healthcare workers as well, and they are considered for candidates to receive this vaccine. Question about the new CDC close contact quarantine. If a person wishes to test 48 hours prior to the 7 days and test negative, that test can be an antigen or PCR. But even people who took an antigen test in the past still have to quarantine, even if it was an antigen test. Yeah, good question. Okay, how the CDC guidelines shorten is based on a study at the Lancet published recently. And essentially, it had to do with the shedding of the virus. The PCR test is a very sensitive test, which looks about RNA and genetic material. So you can be shedding few days after you have the infection and the infection is gone. You can still be shedding, your body can still be shedding remainings of the virus, DNA material, the RNA material from the virus that will be easily picked up on the PCR testing. But that doesn't mean, if you're shedding dead virus, that doesn't mean that you are infected, but you're still going to have a positive testing. So that if you are critically ill, you can shed virus or PCR, you can have a positive PCR for weeks after, but that doesn't mean that you are infectious any longer. That's one thing. And the second, they look at, how often people comply with 14 days of quarantine, and that's too much to ask. And then, so they have only 50% compliance on quarantine because people get bored or desperate or they need to work, and they try. So looking at that, they say that shorten the quarantine for people with minimal symptoms to 7 to 10 days, and particularly if you have a negative PCR. I disagree a little bit about the negative or positive PCR or the rapid antigen testing, because you never know if you test negative today, if you don't know if you're going to be positive the following day. But with or without the testing, shorten the quarantine for infected people, or for people who are, isolation is the term for people who are infected. Quarantine is people who were exposed to an infected person, that's quarantine. So those are the terms. So both of them are shortened, particularly in people with mild symptoms. Look at the CDC guidelines. All right. I think I will have to go. I wish I could stay a little bit longer, but my duties here require me to leave. But I will be more than happy. There's another webinar in the subsequent weeks. I will be more than happy to give you another update and keep on talking to you. The community of Manitowoc have been fantastic, have been great, have been engaging, and all people who's watching this, please spread the word, be patient, educate people. A lot of people don't have access to information or don't have time to educate, and that's the main problem. So get good information, spread good information, be patient, do your fair share of this. The light at the end of the tunnel is around the corner. 3 or 4 months of waiting, it's nothing compared to what we have gone through during 2020. I'm wishing you, everyone, safe and happy holidays.
Thank you, Dr. Mendoza. Greatly appreciate your time and your expertise. And thank you everybody for participating. And please know Dr. Mendoza has a Facebook page that you can follow him and all of his information. So thank you. Bye-bye, everyone.